All right, the last of our disease examples for this chapter is Rh isoimmunization. This also has a couple of other names, erythroblastic fetalis or hemolytic disease of the newborn. All of these kind of tackle the same sorts of mechanisms here. We're going to go through this pretty quickly because I think most of you have heard of this. We talk about it in anatomy and physiology, so we're not going to spend a ton of time, and I think it kind of just makes sense intuitively how this works. So first, I think we need a quick little review of blood types. Red blood cells are produced on their cell surfaces. They have specific antigens. Those antigens can be A type or B type. If a cell doesn't have any of those antigens, we call it O type. Or in addition to these, we also have an Rh factor. So Rh factor, I'm just going to do a plus if it's there. And then these ones are minus because they don't have it, or I'll just leave them off. So this would be an example of an Rh positive red blood cell. None of these have it, so these would all be Rh negative. So these are just antigens that exist in or on the cells, red blood cells, that help differentiate between self and non-self. Again, red blood cells don't have MHC class 1, so they don't fall into that same sort of category. But blood types are determined based on the antigens present on their cell surface. All right, so what happens specifically with this Rh with this Rh isoimmunization? Generally, you tend to have a mother, not generally, you do. You have to have a mother who is Rh negative. So she has red blood cells that don't have an Rh antibody on them. So these are red blood cells, no Rh antibody. So what can happen is if she mates with someone who is Rh positive, the baby can then be Rh positive, producing red blood cells with that Rh antigen on its surface. Now, the goal of these antigens is to help the body determine what is self and what is not. So, if the mother detects that there are Rh antigens in her blood, she will produce anti-Rh, or what we also call anti-D, or that make a big D, anti-D antibodies. So these are antibodies that specifically target this Rh antigen. So what can happen is if the mother is Rh negative and then the baby is Rh positive, during parturition or during other trauma, maternal and fetal blood can cross the placenta and a little bit of the fetal blood can get into the maternal circulation. This would sensitize the body, the maternal circulation, to then start producing these anti-Rh antibodies, things that weren't present prior. So the baby has undergone parturition, it's out of the womb, so there's not really a problem for this baby. But what can happen is during the second gestation, these anti-Rh antibodies, if the baby is Rh positive again, can make their way across the placenta and start attacking the red blood cells of the fetus. Manifestations of this can exist at varying stages depending on how severe it is. For the fetus, if enough of these red blood cells get attacked with antibodies, they can be completely destroyed, and that can lead to anemia. Depending on where these then accumulate, you can get hydrops, which is just edema in fetal tissues. So different tissues can start swelling as a result of the inflammatory response associated with this. In severe enough cases, this can lead to death because you're not transporting enough oxygen to the fetal tissues. In infants, after parturition, there can still be some prolonged effects. What happens when we destroy red blood cells is that part of the porphyrin ring of hemoglobin, that pigmented portion of the hemoglobin, gets broken down into bilirubin. And bilirubin is toxic, especially unconjugated bilirubin. Now, in the fetal tissues, this bilirubin can start accumulating in the brain, forming what we call kernicterus. This kernicterus causes damage to brain tissue, which then can support all of these or lead to all of these clinical manifestations. Lethargy, loss of hearing if it took place near the cochlear nerve, cerebral palsy, learning problems, just from destruction of nervous tissue. So diagnosis is going to be done through our history and physical examination, again, looking for those symptoms. If the mother is Rh positive, there's really not any worry about this. However, if the mother is Rh negative, then we start doing screening tests. Usually during the normal scheduled checkups that happen throughout prenatal care, ultrasounds would be conducted to make sure that the baby is growing correctly, looking for the presence of hydrops, that fetal swelling. If the mother is Rh negative, and there's the possibility that the baby might be Rh positive because of the father's blood type, they can do an amniocentesis where they actually stick a needle into the amniotic fluid, pull out a sample, and then measure the concentrations of bilirubin. In extreme cases, they can actually do a fetal blood sample by taking a draw from the umbilical cord, but that's pretty extreme. Lastly, for treatment here, really the goal is risk reduction. We're trying to prevent the maternal blood from becoming sensitized first by producing too many anti-D antibodies. That really should be the goal. Women who do go through their normal prenatal checkups, usually they are blood typed to see if they have Rh negative or Rh positive blood. If they are Rh negative, then they'll usually test the father's blood. If that can't be determined, what they'll do is just give a prophylactic dose of Rh antibodies. These antibodies will make their way into the maternal blood. If any fetal blood happens to cross the placenta, those Rh antibodies or anti-D antibodies will mop up that blood before they can sensitize the mother and help prevent the production of maternal anti-D antibodies. So really trying to prevent the reaction from taking place initially is kind of the best, prevent the maternal circulation from making its own anti-D antibodies. But if for some reason that's not possible, kind of the last resort is an exchange, a transfusion. And this is pretty invasive. So you would have to use an ultrasound. You would guide the needle through the walls of the abdomen, then through the walls of the uterus, into the amniotic sac, and then try and pierce the umbilical cord just right so that then you can suck out damaged red blood cells and pump in fresh red blood cells from a donor. And if that sounds crazy, it kind of is. There's so much that can go wrong with that, so this would obviously be like a last resort. I mean, I've had a hard time donating blood before where the person is trying to find my vein here, but like imagine trying to use an ultrasound with a giant needle to go through multiple layers of skin and muscle to find the umbilical cord and pierce it just right so that you can get blood withdrawal and blood infusion. Like it's going to be crazy. So this is Rh isomerization.